Hello, everyone, and welcome to our Essential Tremor Virtual Education Forum. My name is Patrick McCartney. I am the Executive Director of the International Essential Tremor Foundation. Today, we're going to be hearing from Dr. Alfonso Fasano on orthostatic tremor. Before we get started, though, I'd like to thank our corporate partners, Cala Health, Boston Scientific, Praxis Precision Medicines, SteadyWare, Insightec, Villamball, AbbVie, and Allevion Therapeutics. Their support allows us to provide these webinars and our podcast series. Now, I'd like to introduce our speaker, Dr. Alfonso Fasano, who is a member of the IETF Medical Advisory Board. Dr. Fasano holds the chair in neuromodulation and multidisciplinary care at the University of Toronto and University Health Network. He is a member of the study group on tremor of the International Parkinson's Movement Disorder Society, the Tremor Research Group, and the Parkinson Study Group. Dr. Fasano received his medical degree from the Catholic University of Rome, Italy in 2002 and became a neurologist in 2007. After a two-year fellowship at the University of Kiel in Germany, he completed a PhD in neuroscience at the Catholic University of Rome. His main areas of interest are the treatment of movement disorders with advanced technology, pathophysiology, and treatment of tremor and gait disorders. He's also authored more than 300 scientific papers and book chapters. So, Dr. Fasano, welcome and thank you for joining us today.
Thank you, Patrick, and I want to thank the Foundation for the opportunity to present on orthostatic tremor, which is a quite rare condition, but not that rare. And unfortunately, in my experience, I've noticed that a lot of people, when they're diagnosed with this condition, they are not really sure about what it is. They haven't never heard about it. So it is nice to talk about orthostatic tremor because I'm sure it will be beneficial to our listeners. Obviously, I don't have to say much about what tremor in general is. I just want to make the point that this is a rhythmic movement of the body. So any muscle can shake, and therefore even the legs, the trunk can shake, which is a particular characteristic of orthostatic tremor. There's a new classification of tremors that's been published in 2018. And here I just want to emphasize that clinicians usually look at the characteristic of the tremor, and based on that, they formulate a diagnosis that we consider a so-called axis one. So the very first level of the diagnosis, in this case, will be orthostatic tremor. But then there's an additional axis an additional layer in the diagnostic process, which is identifying what's the cause for that tremor. And I'll tell you a bit more about the cause of orthostatic tremor, which is for most part a condition where we cannot find the real cause. An important feature that we look at when we describe the characteristic of tremor is whether the tremor is present at rest or during posture or action in general. And obviously, in orthostatic tremor, we are dealing with a tremor that is only visible when the person is standing. So it is somehow related to the action tremor. And another clinical characteristic that physicians look at is where the tremor is present. And as I indicated before, the lower limbs and or the trunk are involved in orthostatic tremor, and also indicated the activation of orthostatic tremor. So the person suffering from orthostatic tremor needs to stand for the tremor to be present. It is debatable whether you might have tremor elsewhere in the body. There are some reports of some mild tremor on the arm or even on the jaw, mainly elicited by the standing position. But in most cases, really, the tremor only affects the lower part of the body. An important characteristic of orthostatic tremor is the frequency. So how frequent these oscillations I described earlier are present. And as you can see from this picture here, this is from an old paper, orthostatic tremor is very far from the classic frequencies that we see for other tremors. It's actually the fastest tremor that we see here, usually with a frequency of 14 to 16 hertz, so meaning cycles per second. It's very fast. And the reason we don't always see the tremor, but the patient can feel the tremor, is exactly that. It's so fast that the naked eye might not necessarily recognize the tremor. This is why we often need to use electromyography. This is a person suffering from orthostatic tremor with a needle in the muscle. The patient is standing. There might be a little bit of tremor in the upper limb, as I indicated earlier. But really, what makes the difference is this fine tremor that is in the legs. And from the video, you don't see even much. But then at the EMG that you will see here in the first part of the video, there's this frequent activity that we can measure, and usually the frequency I indicated earlier is quite characteristic of orthostatic tremor. Uh, Other people argue that there are other ways to detect the tremor, and I'll tell you something more about this in a few slides. But I think I want to spend a little bit of time describing the three types that I talk about when I talk about orthostatic tremor. There is a so-called primary type, which is a condition where you only see the tremor and there is nothing else associated in terms of the condition. There is no abnormality at the brain MRI or CAT scan. And this is a condition where we often don't know why this is happening. Although in recent years, and I've seen a family, there's been some attention to a gene called SPG31. That is a gene that is known to cause another neurological condition called spastic paraparesis. So this is the same gene, but for some reason in some family, all it causes is this tremor. Then there is the condition of orthostatic tremor plus, which means that the orthostatic tremor is seen in the context of another neurodegenerative disease like Parkinson's, PSP, and other neurological conditions. So it would not be impossible to have orthostatic tremor and something else. And this is something a movement disorder neurologist would be able to discern. And lastly, there is a symptomatic orthostatic tremor, which are tremor, quite rare, caused by a lesion in the brain, usually in the posterior part of the brain, around the cerebellum, or another part called brainstem. The brainstem connects the brain to the spinal cord. So these are the three types of orthostatic tremor. In reality, there is a fourth type that I'll tell you in a second. But see, this is another case where you can easily see the tremor, the shaking that this person has only when she stands. When she's sitting, when she's lying down, there's no tremor. And in this case, you can see the tremor because the tremor has been going on for so many years that it's so ample. So the amplitude of the tremor and also the frequency has reduced so that you can actually, with the naked eye, see the tremor. But often people don't even see the tremor, as I indicated before. And here is important what the person living with this problem describes to the doctor, because they will say that they feel unsteady when they stand up and they don't even know why. And they notice that they can't really stay still in a standing position for too long. Either they sit down or they start walking. That's another characteristic. And what this video shows is a patient suffering from orthostatic tremor. Actually, this is the same person that I showed in the other video. And you will notice that when she walks slowly, she's more unsteady. Instead, when I ask her to go faster, she does better. And the example I always make is the one of the bicycle. When we ride a bicycle, it is easier to go faster, isn't it? So the same applies to orthostatic tremor. And the reason is very simple. When we stand, when the foot doesn't move, so it touches the ground, the tremor activity starts and gives a sense of instability. So if you go faster, the time that the foot is on the ground is reduced, and this feeling of instability is less present. Unfortunately, over time, even this strategy is not useful anymore. I indicated before that sometimes you can diagnose orthostatic tremor even without an electromyography, without the needle in the muscle. And this is something I've done in this particular case. This is a woman suffering from Parkinson's, but also with orthostatic tremor. And the reason why I thought about orthostatic tremor is because she felt that she was unsteady standing, and this unsteadiness went away while walking. In Parkinson's, we might have unsteadiness, but usually that's worsened by walking. Now, here it's the other way around. So I had the idea to use a cell phone, my smartphone, and to place it in her sock, in her socks. And as you probably know, smartphones have the ability to record any rhythmic oscillation and to analyze it because they have accelerometers inside. And so you can see here, this is the right and the left leg. You could see this red peak, and this is the high frequency tremor that we could measure in this woman, even though from the video you don't really see the tremor. I would just want to talk a little bit about the differential diagnosis of orthostatic tremor, because as I said before, it is a rare condition. There are many other conditions that can cause tremor affecting the legs. What you see in this video on the right is a woman with dystonic tremor. It's a tremor caused by dystonia. but also you will see that there are other conditions where more often you may see tremor. On the right here, you see PT. We notice lower limb involvement in Parkinson's tremor in close to 70%. Other condition is intentional tremor, which is the tremor you see in cerebellar disease. FT stands for functional tremor or psychogenic tremor. Often they involve the legs. I already mentioned DT. And then lastly, essential tremor. Not often, but essential tremor can also affect the legs. So some people with essential tremor can indeed also have a tremor of the legs, but the clinical characteristics are different, and the neurologist usually is able to make the distinction. I earlier said that sometimes other parts of the body can shake, and in the past there was this condition, which is quite interesting, of jaw tremor, very high frequency, the same frequency of the legs that I indicated earlier, mainly triggered by the standing position. And so this tells us that there are some sort of circuits in the brain that are very sensitive to the position of the body, and they can trigger some tremor in different parts of the body. In the differential diagnosis of orthostatic tremor, there is also the so-called slow orthostatic tremor, which is a tremor at a much lower frequency, between 4 to 12 hertz. So it's a slower tremor. And there are some primary forms. So some patients with a slow orthostatic tremor, and we don't really understand at this moment what these people have. But more commonly, there are secondary forms caused by lesions in the brain, by autoimmune diseases. But I think the most common of this slow orthostatic tremor are those tremors affecting the leg and the trunk in Parkinson's disease, which are different than the one I showed you before. These are the classic low and slow tremor that Parkinson's patients might have with a good response to medication for Parkinson's. This is why we can easily distinguish if this is a tremor coming from Parkinson's or a different type of tremor, because unfortunately, orthostatic tremor tends to be quite resistant to medication. In recent years, we had the opportunity to use many ways to understand the brain and how the brain functions, even in people suffering from orthostatic tremor. And I want to show you the case that you see in this video. Again, you don't see much tremor in the hand, but this man indeed suffers from orthostatic tremor that you see when he stands. And so this man happened to also have an electrode in the brain, so because he was treated with deep brain stimulation, and some deep brain stimulation devices are able to record the brain activity. And so we could actually see what happens in the brain when the patient from sitting stands up. And all you see here is a similar P that I showed you earlier in high frequency at around 14 hertz in the brain. So clearly indicating that in this particular part of the brain, that is the thalamus, there is this pathological oscillation at the same frequency of the tremor in the legs, indicating that we were really in the right spot for stimulating the brain and trying to help this person. So this gave us the opportunity to do other experiments, also putting this patient on a tilt test, so we could see what happened to the brain and the legs while we were moving the body. And as you can see, you don't have any tremor and no brain activity appear when the patient was lying down or even when he was tilted just slightly. And the tremor only appeared when he was at 90 degrees, when he was fully standing. And during walking, as I indicated also earlier, there was some tremor in the legs, but also in the brain. So what about the treatment? I already told you that the treatment is very often ineffective, and this is a big problem. Usually the medications with the highest success are gabapentin, clonazepam, which is a sleeping pill, while gabapentin is an anti-seizure medication, and then levodopa. Levodopa probably because in some of these cases there is underneath some Parkinsonian condition. Levodopa is the main drug used to treat Parkinson's disease. And often in my practice, I end up combining these three drugs. Gabapentin seems to be the most effective, but really sometimes you see the difference when you start adding other drugs, unfortunately. And I'm saying unfortunately because it means that the person suffering from orthostatic tremor is exposed to multiple drugs. And sometimes these drugs come with side effects, as you can imagine, particularly drowsiness. There are many other drugs that have been tried in orthostatic tremor with very variable findings and results. I listed few there, including the drugs that we use in essential tremor. But let me clarify, orthostatic tremor is not a subtype of essential tremor. In essential tremor, we might have leg tremor. We might have leg tremor visible during standing, but there are many other characteristics typical of essential tremor that orthostatic tremor doesn't have. And when these pharmacological treatments don't work, then surgery can be considered, even though this is off-label. And this is functional neurosurgery. I mentioned deep brain stimulation before, and it's been found that usually bilateral implants are better than unilateral implants. So two electrodes in the two parts of the brain, or maybe in theory also focused ultrasound, which is a new procedure, a new way to do brain surgery. So let me tell you about deep brain stimulation in just a few words. The electrode is placed in a part of the brain called the thalamus, which is important because it receives a lot of information from all over the body, particularly from the cerebellum, which is indeed implicated in the pathophysiology of orthostatic tremor. So a while ago, we looked at the patients reported in the literature treated with DBS, and somehow to our surprise, we noticed that yes, DBS works, because if you see here, these people receiving deep brain stimulation can stand for less than 20 seconds before surgery on average, but then after surgery, they can stand up to 200 or more seconds without needing to move, to walk, or to sit down. But as you can see from this graph, little by little, the effectiveness of the DBS procedure reduces over time, which is a problem. So this is why in recent past we did an experiment because we can now record the brain activity, and we activated, and this is off-label, adaptive stimulation. So it's a closed loop stimulation in the brain that adjusts and responds to the brain activity that I indicated earlier, this 14 hertz in the brain, so that the more brain activity there is, the more the stimulation goes up. And in this particular subject we published last year, we noticed that when we have an adaptive stimulator on the far right, we have better tremor control as opposed to continuous DBS, which works, but is standard of care, not always that effective. And obviously, the worst is when stimulation is turned off, because you see the tremor more often and the patient needs to sit down. And this has translated also in an improvement of quality of life and other metrics of tremor severity up to 2 years. Because we can record the brain, we can also see what happens to the brain over time. And so we could also record the brain activity, for example, at night. You can see that while the patient is asleep and is lying down, there is no brain activity. But then when the patient gets up in the morning, this is around 7 a.m., the tremor activity starts, so the stimulation changes at the same time. I mentioned focused ultrasound because it's a new treatment, and many people suffering from tremor ask about it. So focused ultrasound is done lesioning the brain using sound waves, which are sent to the thalamus, the region I already mentioned earlier, uh, and in order to destroy the neurons causing the tremor. Now, so this is often used for essential tremor, but it's not. And actually, in the States, for example, in 2021, there were more focused ultrasound procedure than DBS. The question is whether this procedure can be used for orthostatic tremor. And the answer is difficult to be given at this moment for two reasons. First, orthostatic tremor is rare, and there are very few people treated with focused ultrasound. Second, focused ultrasound is a permanent lesion in the brain. So to be on the safe side, usually we do it on one side of the brain only. So the two lesions can be done these days. In theory, you can do it, but this increases the risk. And as I alluded to earlier, for orthostatic tremor, we want to stimulate, in the case of DBS, both sides of the brain. And in the case of focused ultrasound, in theory, we should be lesioning both sides of the brain. But with two permanent lesions, there is higher chance to have a problem with balance or with speech. So I think at this moment it's very difficult to say whether orthostatic tremor can be treated with focused ultrasound. But I wanted to say a few words because I'm sure that people out there listening to this presentation will be wondering whether this treatment that they saw on TV, on the news, and the media is applicable to their case. And with this, I want to thank you all for listening. And again, the foundation, the Essential Tremor Foundation, for the opportunity to present to you about this rare and mysterious condition. And I hope we'll have the chance to answer questions later. Thank you.
Awesome. Well, thank you, Dr. Fasano, for taking the time to speak with us today and sharing some great information on orthostatic tremor. We hope everyone found this presentation helpful and hopefully you learned something new today. I know I did. I always thought orthostatic tremor was part of essential tremor, so that's good to know. So, if you have any questions regarding essential tremor or orthostatic tremor, please visit the IETF website at essentialtremor.org or you can call us toll free at 888 387 3667. And finally, if you are a donor to the IETF, we want to say thank you for your support. If you aren't currently a donor, we hope you consider a gift to help us continue the work we do for promoting ET awareness, education, support, and research. So we host a variety of these virtual education events. So look for notices about these events in your Tremogram e-newsletter, on our social media, and our Tremor Talk magazine. So again, thank you for joining us today, Dr. Fasano, and we hope everybody has a great day. We hope you have some safe travels, Dr. Fasano.
Thank you.